Meeting is called to order. Jeffrey, if you would please call the roll.
Bishop Badger. Ron Bennett. Reverend Blue. Ron Chapin.
Here.
John Dandies.
Here.
Darby Fishkin.
Here.
Katie Grimm. Sharon Hansen. Mike Hoffert. Christian Johnson. Jim Lewicki. Chris O'Brien. Jennifer Persico.
Here.
Jack Quinn. Gina Rusi. Michael Seaman. Ben Swanekamp. Yes, we have a quorum.
Let the record show that we have a quorum, and we'll go right to the approval of the minutes unless there are any additions, deletions, or corrections. I will be happy to accept a motion to approve them as presented. Is there such a motion? Motion has been made and seconded. All in favor? Thank you all very much. We'll go right to the resolutions. And first, Ms. Persico.
Hi, everybody. Sorry I can't be with you in person. Clearly, I can never get my dates straight. I'm sure that our chair had at least one or two jokes to make about that earlier. I'm sorry I missed those as well.
I haven't started yet, Jen.
Oh, yikes. In any event, the Contracts Committee met on July 21st and discussed the list of contracts that you have before you in your board packet and recommend that the full board approve those contracts.
We're good? Thank you, Jen. We don't need to approve those, do we? We do need to approve those. Jen has made the motion. Is there a second? Ms. Hanson, any further discussion, questions? All in favor, please signify by saying aye. And opposed?
Aye.
Thank you. That motion carries. Dr. Cummings, I think he was going to try and be on the line. If not, Dr. Murray.
Adrian, do you know if he's on? No. Okay, I'll go ahead. There are two items from the, yesterday's Medical Executive Committee meeting for the board to consider. The first is the monthly credentials committee recommendations. July is always a period of significant turnover with the medical staff because it's the start of an academic year. So we have, on the good side, we have 20 initial applications. On the other side of the ledger, we have 21 resignations, which is not unusual at this time of the year. There were also 41 reappointments. Of note, on 6/24/21, the New York State of Emergency ended, which also ended all executive orders, including the possibility of having disaster privileges for out-of-state physicians, and that's one of the reasons for the resignations of some Apogee providers. The Medical Executive Committee also approved a new privilege for approval by the board. This is the creation of intraosseous vascular access. This is a procedure during a cardiorespiratory arrest where the patient, we can't get intravenous access on a patient in an emergency where they actually go through the bone to give medications. It's obviously restricted to people with special training. So that's the report from the Credentials Committee.
Thank you, Dr. Murray. Has the motion been made to accept the report from MedDen? Mr. Seaman, is there a second? Bishop Badger, any further questions, concerns, issues? All in favor then, please signify by saying aye. Aye. And opposed? Aye. That motion carries as well. Thank you. Dr. Quattrocchi.
The second item.
Oh, I'm sorry.
Yeah. Yesterday,
I thought that was the first item, Dr. Murray.
Yesterday, the Medical Executive Committee unanimously recommended that the board grant permission to Dr. Rickard Brainmark of the University of Gothenburg in Sweden to participate in the surgery of up to 3 patients. The purpose is to train ECMC-based surgeons in the orthopedics and plastic surgery departments in a new revolutionary and groundbreaking surgery that has the potential to greatly improve the lives of people with above-knee amputations. Dr. Brainmark developed this procedure. He has neither a United States license nor boards in surgery here. However, New York State education law, Article 131, does permit a physician, and I'm quoting here, to practice medicine within the state without a license, who is licensed in another state or country, and who is visiting a medical school or teaching hospital in this state to conduct medical instruction, provided such practice is limited to such instruction and is under the supervision of a licensed physician. The matter is also being discussed with senior administration and hospital legal counsel who support that recommendation. It's a unique opportunity for us to learn and be able to potentially offer this new procedure to our patients. It is also FDA approved, but it was just approved in December 2020.
Thank you, Dr. Murray. Is there a motion? Bishop Badger, second Reverend Blue. There's got to be at least one question about what he just said. Maybe not. Well, I have it. Exactly what happens?
As you know, normally an amputee has a kind of prosthesis that's kind of strapped onto the leg. And that's actually, quite apart from the discomfort, it's difficult, and there's also a lot of complications. There can be skin breakdown and things like that, but it's one of the best things that are available. Here, what they use to connect the exterior prosthesis is actually a device that is inserted into the bone and brought out through the skin. It's eventually a screw. It's a two-phase procedure. Initially, a device is put in into which the screw will be inserted. It take a couple of months to adhere to the bone to make sure it's secure. Then the screw is inserted and brought out to the skin to connect to the exterior prosthesis. One of the remarkable things about this is that there's preliminary evidence that, quite apart from the better functionality, that the people can actually sense something in the foot through this process. And that's actually an area of ongoing research that the group also want to pursue. So it is a radical change. Now, it's not suitable for everybody with an above-knee amputation. Right now, it's specially selected patients.
Dr. Murray, which of the doctors on our staff are going to be participating?
It's primarily Dr. Laurie and his group are doing the plastics end of it. And of course, our orthopedics department, I think it's Mark Anders and Dr. Diskin who are currently involved. And obviously, this has the endorsement of both chiefs of service.
And Dr. Laurie is involved.
Yes, he is.
Fascinating. Other questions? Christian?
Well, the special equipment is the actual device, which is unique to this procedure, though it's a titanium-based device, which is very similar to for instance, an artificial hip is that's inserted into the bone. So it's an adaptation. Also, these implants were originally developed to do dental implants. They've been used for 30 years for dental implants. And actually, Dr. Laurie has used this. Actually, it was the father of this surgeon who developed the dental implants. And, so in that sense, it's an adaptation of an established procedure. It could potentially, but it's too early to say. That's one of the questions of whether this reinnervation would impact that. But I don't have any data to say it helps that, but at this point.
That's tremendous. Fascinating. Thanks to you, Dr. Murray. Any other questions? Motion has been made, seconded. If there are no further questions, we'll come immediately to a vote. All in favor, please signify by saying aye.
Aye.
And opposed. Thank you. That motion carries as well. Dr. Quattrochi now.
Thank you, Mr. Chairman. Let's see if these will advance. Adrian. Yo, Adrian. Yeah, we try it. All right, I think I did that. Did I do that or did you do that? Okay, great. All right, so first of all, I wanted to obviously keep the board updated as to our COVID patients. We are very fortunate this time that we have only three COVID patients in-house, but we have today, as of today, treated 1,300 COVID patients, and you can see our length of stay it continues to be about 13 to 14 days. And as we've talked about before, we're very fortunate also to have 87% of our employees vaccinated, our ECMC families. So again, right now, obviously COVID continues to be manageable, but we're keeping an eye on the Delta variant and making sure that we are prepared for a possible fall surge. You can also see we continue to do a lot of vaccinations. We've done a lot of vaccinations and continue to do them for the community and for our ECMC family, and have done over 35,000 to date. Another item of note, we have had 98 kidney transplants year to date. That's the most ever at this point in time. So if that trend continues, we should well exceed the 150 transplants for this year. So we'll keep the board updated on that. The team's been doing a phenomenal job, and we continue to have the shortest wait times in the country. And many people from across the nation are choosing us because of that. Our lab survey was just recently completed by the New York State Department of Health. They did a wonderful job with that survey, and lots of compliments. We do have, as we always do a survey, some items of correction, and we are currently undergoing our radiology survey. These are our hospital-acquired infections, and I'm going to, Donna, if you can grab a mic, maybe come up here and see John. I was going to have you very quickly go over this and talk about our results.
Hi, thank you. So thank you all for your feedback last meeting. So this time we have a more description of the hospital-acquired infections as well as the patient safety indicators. This data is publicly reported, and this is just a snapshot. There are many metrics that we monitor every month. To note, for the catheter-associated urinary tract infections, the CLABSIs, the C. diff, if you look in the fourth column there, the SIRS, we like that to be less than 1. So that's our standardized infection ratio. So that means we're doing very well. So we'll continue to work towards improving and advancing along our journey to zero harm. The indicators below, those are called the PSIs, and we certainly have a lot of robust initiatives going on to ensure that we continue to drive those numbers to be as low as they can. So I think we're on the right track.
Thank you, Donna.
Thank you.
And as I mentioned before, we have many robust committees around all of our patient or hospital-acquired infections. And considering how busy we were in June, this is quite remarkable. So really good work by the clinical team and by those working with the clinical teams to make them aware of some of the practices. Our human experience, patient experience, we have continued, as most have in the country, to lag a little bit behind on scores. And you can notice again that N up top, that 507 versus 735, hasn't caught up yet, but we are embarking on some initiatives to reconnect, refocus, and reimagine human experience, especially within our new existence post-COVID. And we reinstitute what we call a monthly hour of power, where we meet with many managers to talk about patient experience and how we can improve it. And we're really getting back to kind of blocking and tackling with each of the units and having them look at their scores so that they can improve patient experience and the human experience at ECMC. Thank you to the board who were able to participate in our employee picnic. It was a wonderful event. It was great to have everyone gather again, and everybody did really, really enjoy it. It's the first time we've gathered together as an ECMC family since the pandemic started. So it really, really made a big difference in morale at the institution. We have the foundation obviously had their tent sale again. And Sue, remind me what our final number was, 57? 56,000. $56,000 worth of merchandise sold where ECMC employees reached into their own pocket to have an ECMC logo apparel. And it's really just, again, a testament and a real indicator of the pride that the employees show for ECMC. And Sue, you and your team did a wonderful job this year. Thank you again for that. We are presently part of what's called Give 716 promotion. We've had a lot of success around that. And again, thank you to Sue and her team. We've done online auctions. We have our golf tournament on August 9th. Unfortunately, I believe we're sold out, so you'll have to find somebody who will force them to play. And we're planning on our Springfest Gala this year, October 30th. We're continuing to monitor the situation, obviously with the Delta variant, but we're hoping we're going to be able to do that, but we'll see as time moves on here. The window project continues to be on schedule. Thank you to Jim and his team, especially in the midst of all the rain that we had this past month. Our med-surg overflow opened. I talked about that. It was the old ER, the new area. We opened that, 7 beds. We need as many beds as we can these days. It's been so busy. We're also getting recognized with Business First for both the Key Bank Emergency Trauma Center and also our lobby. And as we've talked about, we continue to exceed our MWBE goals through this year, and we're continuing to focus on making sure that the community, the entire community, participates in the economic growth at ECMC. So just a couple things, but I don't want to steal John's thunder here, but obviously June was a very, very busy month for ECMC, and you can see our discharges continue to grow. We also are continuing to see a little bit of a decrease in inpatient surgeries and that movement to outpatient that we've talked about. Frankly, that's been somewhat of a blessing for us because the place has been so busy and it's been hard to get beds. So if we had that inpatient volume, it'd be an issue. And then also, again, you can see our emergency room volume continues to increase. So with that, John, I'll turn it over to you. And John's going to talk a little bit about our financial results this month.
Great. Thanks, Tom. So as Tom mentioned, June was extremely busy, and you can see it here in the discharges. They're up 7.6%, and that's despite the decline in inpatient surgeries that you can see down below, about halfway down the page. Those were down about 10.5% from budget. As Tom said, it's just indicative of that accelerated shift into the outpatient setting. And you can see that certainly in the line right below the inpatient surgeries and outpatient, as they've grown above our budget, about 27.5%. The cost profile that this has driven remained high during the month, but it's really been driven by volume, and you'll see that in a moment. Just another note on this slide, as we look down our finance dashboard, you can see here that in red, the only red on the page in the month, is related to the average length of stay. A lot of continued efforts. Tom's talked about it. Daily blocking and tackling as it relates to moving patients through the system. Imperative to do that, to try to maintain the continuity of care and the efficiency of care and the comfort for our patients. Still remains high. It's about a day over the budget, but constant work, effort going in that every day, twice a day, and sometimes all day, just trying to make sure we manage that. That certainly does play itself in to some of our additional cost. You can see our volume-related FTEs are a little bit higher than planned. Here, they're about 3,496. Our budget for the year, about 3,462. I know I've mentioned this, but you'll continue to see this grow slightly as volume continues to increase, and as we've seen through this summer and through the end of the trauma season here. Next slide. So the good news is, for the month, that volume brought a higher performing month. Albeit still a loss, we had anticipated a loss of about 2.9 million. We came in and performed at an operating loss of about 2.1 million. So we outperformed our plan by nearly 800,000. And then when you add in, excuse me, the non-operating income, that variance grows to nearly $1 million for the month. And as you recall, if you look at the next slide, coming into the month, our overall variance from plan was just over $10 million. We've now reduced that to about 9.4 million, just given the good performance during this month. So movement in the right direction, high volume month, really a variance that was indicative of the high volume month. And so we're pleased with where June came. Looking at July, because July volume is a little bit softer, but we'll keep an eye on that. Next slide. So as we continue to track the overall impact of COVID on our organization, you can see here from the beginning of the year, the impact was about $13.3 million. That includes both lost revenue and additional expenses, many of which we did budget for, but nonetheless, COVID related. So when you add that to where we were coming into the year, our total impact through June is roughly $110 million. And that's, of course, before a couple significant items. That's before any relief that we would have received last year. But it also does not include the significant additional pension expense that we recorded in 2020. Just want to make sure that we keep that in front of us, because that was an impact that was indirectly COVID related, just due to timing. And just a couple of updates on the next slide. So we've heard a lot about the undistributed money from provider relief. That, unfortunately, at this point, there's no new news. There's still no indication as to how much, when, to whom, or how that will be distributed. Still a significant amount of advocacy there, both locally, nationally, amongst all of the providers, trying to understand what's happening there. Our days cash continues to be strong at this point. We do anticipate that coming down, as we've talked about, primarily, specifically related to the loan payback for Medicare that began in April. The additional initiatives, happy to answer any questions on those. Those are all in process. But just lastly, we're right in the middle of our 2022 budget process. Right now, we're working with department managers on their individual budgets. That budget process will culminate in a presentation to the Finance Committee and then the board in September. Happy to answer any questions. For those on the call, the question was, are we anticipating any additional costs if there's an additional surge? And of course, yes, we would, but it's too early to predict. I can just.
Go ahead, John.
Yeah, I think rather than maybe categorizing it as cost, I would categorize it as just it puts a strain on the rest of the organization, because we have to then reinstitute a dedicated unit or two or three as the surge progresses. So it prevents us potentially from admitting other types of patients and those types of concerns. But yeah, we do know the costs per patient. We can get down to that level, and we can certainly come back to the board with that.
Yeah, I was going to say the biggest impact obviously was the surgeries, right? So as long as we're not suspending surgeries again, I think we can mitigate the costs with the additional volume. But as John said, it does slow down the whole system, because the length of stay typically is longer for a COVID patient. And then we may see a higher, for example, left without being seen in the emergency room, which we obviously don't like. So it's kind of that ripple effect as we get busier in the tower, and especially when we have higher lengths of stay, it ripples all the way back down to the emergency department, and sometimes people not wanting to wait. But I think if the surge does happen in the fall, we hope that it's not as large as we've seen in the past, and also the fact that I think we've gotten a lot better clinically, obviously at treating COVID, and obviously operationally. But we're still, because of a lot of the mandates that still exist, we're still absorbing a lot of costs at this point.
And I think just to piggyback off that question, is there any lessons learned review that had happened from experiencing COVID so that maybe we can mitigate some of those costs that we might have incurred from the initial.
Yeah, I would say, and I'll, Andy or Dr. Murray chime in both from an operational and clinical standpoint. I'd say mostly clinically. So if you look at our length of stay, although it's just a slightly lower, many of our patients, and those include ICU patients too. So we've learned a lot clinically about patients, and so that helps with both the cost, right, of treating those patients and also how long they stay in the hospital. So, but I'll let Dr. Murray, if you want to just chime in real quick clinically, and then Andy, if you have any additional items with regard to operations.
Yeah, I don't really have a lot to add, but, you know, these patients, we've obviously learned a lot now how to treat these patients. We have better treatments, and we can get them in and out of the hospital, particularly if they're not too sick. But the problem is the more severe ones do consume a lot of resources. And, you know, that's the major problem, because you're trying to also treat all the other patients at the same time. So I think it's kind of the stress that it induces. It's the pressure on beds. You know, there's increased overtime often and things like that to accommodate the extra patients.
I don't know if I have too much to add. What I would say is that I think we continue to have the task force every Monday and Thursday now, and we're having it every day. I think the lessons that we've learned operationally is that we have to be continue to be nimble, because with COVID, it changed from week to week in terms of the number of people we had, also the severity of the types of patients that we had. So I would say, you know, we had the benefit of, when cyber occurred, to be able to have the task force in place, and we kept that in the huddle process and communication. I think has been really, really good throughout all of COVID for the entity.
You know, as Tom mentioned, the loss of the elective surgeries, it was one of the biggest damaging things. We actually feel we could handle those, that it was not necessary. You know, inpatient surgeries actually are often necessary anyway, but we feel we could have safely continued to provide those services to outpatients separately. You know, and that I think would be one of the things we would fear in another surge, is the loss of those, you know, both for the patients who are not getting the service and for the revenue to the hospital.
Tom, I wanted to get an update on the fire that happened with the PPE, and if there was any damages, and if there's anything that our insurance won't cover.
I'll let our legal counsel cover the insurance piece, but I apologize, and I apologize for not covering that, but we fully were able to replenish our stockpile. I want to thank also County Executive Mark Polenkars in the county, who called me immediately that night and said, how can we help? You know, between the great efforts of our purchasing department, who continues to just amaze us, and during the pandemic, sourcing things from all over the place and doing a wonderful job, we'll be able to replenish it. And I believe from an insurance perspective, we're covered, but I'll let Joe answer that question very, very quickly.
Short answer, we're covered. Painstakingly, obviously the legal team goes back and forth when we preserve these locations with our insurance company. So as boring as it is, and the fact that so many people we negotiate say that'll never happen, it actually happened, and we are covered for our losses. So.
And let the record show that I keep asking, so tell me about the fire suppression system in that warehouse. And no one seems to have an answer. So when I get it, I will share that with all of you. We still don't know, do we? No. Anything else, John? Anything else? Tom? Okay. Real quickly, I have asked Jeffra to circulate the board responsibilities document That is as much an effort to update our file as to be sure that our new board members are fully conversant with what board expectations are, which is a question that we get all the time. So if you would please, for those of you who are here now, please give them back to her before you leave, and those those who are. At some point, we're going to add the whole IT AV element to one of our agenda items. But for those who are watching virtually, if you would please either scan them or send them to Jeffra as quickly as possible. Two thank yous. First, for those board members that attended the barbecue, particularly those who did the midnight shift. Once again, thank you so much for doing that. I continue to get, as I walk around the hospital, lots of people that say, hey, the last time we saw you guys was behind that chicken line. And it means a great deal to our staff, and Sue and Stacy and the foundation staff once again did a great job. But it's those types of things that reflect on our culture that are just so important. So thank you. And having said that, the only other thing that I would add is we look to October 30th for Springfest, and hopefully the environment will allow us to do that. And if you thought watching Andy Davis dance at the barbecue was fun, I can't imagine what that's going to be like within Vogue. So let's keep our fingers crossed and keep praying that COVID variant will allow us to have that. So having said that, Mike Seaman, anything on finance? Great, thank you. And Mr. Bennett on buildings and grounds? Thank you, that was easy. And Mike Hofford, I think you were there, but now you're gone. Was Mike still on? Okay, so we've got no report from QI. Having said that, I think unless there are any other items for the good of the order, we are adjourned. Thanks, everybody.